evaluation skill, for example. And why staffing ATTC can vary. Practical suggestion from respondents is that there should have one dedicated full-time staff to coordinate the effort, and this could facilitate scale up. And we think that this suggestion is a very excellent one for ATTC when they establish the center. The top 4 of the finding on communication and collaboration, there is a great value of being collaborative and having a clear and distinct role for ATTC. Because our International HIV and Addiction Technology Transfer Center work on addiction and HIV and mental health. So we touch a lot of different fields, and there are a range of working on the same topic. So ATTC should make sure that they are working smart, not just working hard. Working smart here means filling important gaps of workforce development, capacity building, and making sure that efforts are not duplicative, but synergistic with what other players are doing. And ATTC feel an invaluable niche, and they need to make sure that others, such as local government, as a partner, policymakers, funders, are aware of their capacity. And technology have to connect ATTC with partners, with patients, with students, and it can be used to promote their distinct and crucial work. In short, ATTC should be using technology to meet their goal. There is a great common idea on the advisory board, and also advisory board is not mentioned as a separate team, but it is repeatedly mentioned under the team number 4 and number 5 in the finding. And as mentioned by the lead agency and implementing partner, as you can see on the screen, so we would love to stress the importance of the advisory board with their role and composition when you establish an international addiction technology transfer center. And we could love to present here also an example from literature review about the advisory board from leading board organizations from UK. They suggested 5 factors that will enable effective of the advisory board, from a well-defined role, purpose, and mandate to the recognition of advisory board members. And we hope that information about advisory board could not cause any confusion in the findings of the top 4 lessons learned as we presented. The study limitations. There are some limitations with our study. This study is...
I'm so sorry to jump in, I apologize. I'm afraid that we will need to move on to the next speaker very soon. So is it okay if you wrap up your presentation now? Thank you.
Okay. Just 1 more minute. And we have some limitation, as you can see on the screen. And because the purpose of this exercise is to have a suggested lesson learned for other entities, they may plan to open international ATTC. So we believe that we succeeded in this basic study. And again, the top 4 recommended lesson learned for establishing an international ATTC is the finance and sustainability, understanding the context, human resource and staffing, and communication and collaboration. For more information, you can visit our website. website of the Southeast Asia HIV-Addiction Addiction Technology Transfer Center, and also our ATTC network website, as you can see on the screen. I come to the end of my presentation. Thank you very much for the kind attention. Thank you.
Thank you so much, Dr. Lee. I appreciate it. Now we're going to move on to Ms. Vaya.
Good afternoon, everyone.
Oh.
Okay.
Okay.
Can you hear me?
Yes, we can hear you. I think there's a little bit of an echo.
Okay, so please turn off the microphone here. Where is it?
Make sure you have one microphone through which you're speaking. There's not two microphones. You might also need to move away from the computer. Sometimes if the phone is near the computer, it might reverb.
If you have the session open on two devices at the same time, you'll have to mute one of the devices. Sounds like you have this open on two devices at the same time in the same room.
Okay, thank you, George. So I know the problem. So good afternoon again, and I'm with Ms. Toung, and we will present the presentation about how we adapt our UMP-VHATTC, the UMP-VHATTC to support the SUD and HIV workforce during the COVID-19 pandemic in Vietnam. And because of the time, we try to be very brief, and in our agenda, we have 4 parts. First, we introduce about our VHATTC, and then we would like to say what we do to adapt during the COVID and the topic trend during the COVID time, and finally the lesson learned. And because we share the duty, and I will present the first part of the program, and Ms. Lee will present the last topic. So I would like to say about our ATTC. The VHATTC is the name of the Addiction Technology Transfer Center Network, and we are affiliated with the UMP, the University of Medicine Pharmacy at Ho Chi Minh City, where we train the healthcare professionals like medical doctor, like public health professional, like the nurses, like the medical technology. And here we have the mandate to train the people working with the SUD problem, and therefore we get the support from the SAMHSA and with the from financially and also technically, and we got the support technically from UCLA and with the money from PEPFAR to do the transferring of technology for treatment of and prevention of addiction. Here and this is we are the university-based center focused on HIV addiction and prevention in Vietnam through intensive training for both in-service and pre-service manpower. Like I told you before, that we have got funded by the SAMHSA and PEPFAR, and with the technical support from UCLA, and we started officially in October 2014. And we are very proud that we use the new technology, like we use the echo distance training, and we do it via Zoom, started from the December 2017. And because of that, we can continue the training during the COVID-19. And our mission, the first mission is to introduce, transfer, and accelerate the adoption of the implementation of the evidence-based addiction treatment, practice, and recovery-oriented services. Second, we heighten the awareness, knowledge, and skill among workforce, address the needs of people with SUD. And third, we act as a bridge to foster alliance among the practitioner, researcher, policy marker, funders, and recovery community. And therefore, to be short, we have the 3 missions. First, we do the technology training. Second, we raise awareness among the public. And third, we do the liaison among the healthcare professionals. To whom we serve, and we serve the workforce in the clinic, hospital, treatment, and intervention center. And we cover own healthcare professionals like doctors, counselor, pharmacists, case manager, PA educator. And our target is our client is the patient and family, and also via the training we can benefit the patient, family, and community. And we directly train the students and the professional, the expert in our university. And we also do the policy advocacy, and therefore we can provide advice to the policymaker and officials from local and national authority agency. And so for the e-service and the pre-service training, and we do mostly in-service. We train and transfer technology for the healthcare professional, and we provide technical assistance by the case discussion and skill building. And we do also some pilot study. And for the students in our university, we do the free service training, and we integrate the addiction medicine to the curriculum and raising awareness about the addiction among the students and the faculty member. And also we provide the lecture, the optional lecture for people here and us. And we do a lot. We are very proud. We have a lot of achievement. We had trained nearly 10,000 participants in the 52 provinces in Vietnam out of the 83 provinces. And we have the 43 key partners, and we organize 608 events. And so our target audience is mostly we target mostly in the clinical staff, like and we provide 31 events to the students and the university lecture, and we also provide training for 19 NGO and other agencies. And now we would like, this is some photo present our activities during time. So now we go to the very important part of my presentation, is that how we adapt to during the COVID-19 pandemic, and by providing distance learning program. And now I would like to leave the presentation to Mr. V, and who will talk in more about it. Please, Mr. V.
Thank you, Professor Dung. As Dr. Dung mentioned that we had to format of the support. We support the face-to-face support and the distance support, and we start off the distance learning program in the end of 2017. And here is the data from over 2 years we support for the distance learning. We provide 68 sessions for over 3,000 participants in 52 provinces in Vietnam. And we divide the topic to main 5 topics. The first topic is a lecture series on co-occurring disorder like depression, and the second group topic is a lecture series on drugs like the drug hormone use for cancer or methamphetamine use. And the third topic, we focus more on counseling and specific therapy for the clinics, like motivational interview and mindfulness and methadone and buprenorphine. Besides that, we also have a case discussion for the clinics like the methadone dose and dropout among methadone patients or polyrectal among methadone patients. And because the COVID-19, we also the group of the topic related with the COVID-19 for the clinics and the community-based organization. This number, this picture can show you that the routine that we are with our VA, the distance learning model. You can see here we are in the south of Vietnam, in Ho Chi Minh City, but the distance, the VA distance model, we can support more routine in the north in Vietnam. And before the session, we inform for the participants via our website or Facebook and the mail list. And after the session, we post into the YouTube and the participants can have a chance to look the session again. Due to the COVID-19, from February, we had a new case in the COVID in Vietnam, and we had to transfer all our activities from the face-to-face to the virtual platform. The blue of the column in the blue, that's all the session we did for last 3 months, 3 years, and the orange one, it's just only 3 months from the COVID-19. And you can see that even the number of the people who receive the certificate due to, for the time of the COVID-19 receive the certificate significant higher than last 3 years. And we also collect some information whether how many people who visit our website and how many people after the training they watch the report session again. And we also develop some products like the guideline, the tool, information package for the participants. And we also have some topics related with the COVID-19 pandemic. For example, we have one session on COVID-19 prevention and addiction for the treatment facility and the guidance for providing methadone and buprenorphine in COVID-19 emergency. And we also have one session on COVID-19 prevention at a community-based organization. And during this time, we also have another topic like methadone maintenance treatment. We have this session, online protocol, and we have 7 sessions on motivational interview and 4 sessions on chemsex and harm reduction among men sex with men and transgender women. Besides that, we also develop the brochure and the brochure related with COVID for the healthcare professional and the patient in the community. After the challenge, we also collect the information to know to receive the feedback from them, and over 90% of the participants they feel that the course that we provide are useful for them, and they satisfy with the section. And after 1 month of the training, we also ask them again whether they want to recommend our course for their colleagues, and whether they expect to use the information to gain their from course. Over 90% they recommend the course for their colleagues, and they feedback that they gain some knowledge and apply it into their patients. And after three years provide the distance, and we can see that via the model we can increase we can reach out more the province in Vietnam, even some very, very remote province in Vietnam, we can reach out them. And we increase the number of participants to attend the session. And we have a diversity of the speakers around the world. And we have a diversity of the topics. We can increase the travel and the cost from the participants and the time. Here is our lesson learned from the model. The first lesson learned, you need to pay attention about the needs from the participant and we respond the needs of the participant as soon as possible. And the second lesson that we provide, we learn from the model, as we provide the knowledge and the TA for the participant, and we can increase the outcome, the outcome of quality of the service for the patient. And the third lesson learned that because we are the online model, we can invite many kind of speakers in around the world, and we can update the training model, and we can have a new perspective and more update knowledge for the participants. And the final lesson learned that we connect with many kind of the experts and in many areas and many places in the world.
I'm so sorry to jump in. Is it okay if I'm afraid we'll need to complete your presentation and move on to the final speaker very soon? So if you could.
Thank you. Yeah, I have just only one more slide.
Perfect.
Here is some picture. You can see the doctor. He can take care of the children and can listen the topic via the online. And based on what we lesson learned, and here is the next test from the future. Thank you for your attention. Yeah.
Wonderful. Thank you so much. That was perfect timing. Amazing. So now we'll move on to our final speaker, Isabel, if she's there, hopefully. Oh, I think she actually might be, oh, perfect. Great.
Can you see it?
Not yet.
Let's see. Craig has my copy of the PowerPoint. Maybe we can use that.
Great. Craig is going to share it now. Perfect.
But can you hear me?
Yeah, we can hear and see you. Great. Thank you.
Okay. Thank you.
I am stop sharing để cho Olivier share đi.
Thank you. Thank you. So thank you, Olivia, for saving my day. I will I'll make sure that you won't have much pressure to interrupt me to end my presentation. But anyway, next slide, please. Or can I control that? Craig?
I think probably he'll have to control the slides.
Can I control the slide? Yeah.
I believe Craig will have to do it, right, Craig?
Yeah.
Okay. So.
Yeah, I'll advance the slides on your behalf.
Oh, thank you, Craig. This presentation is about transforming a walkthrough universal treatment curriculum, which we call it UTC walkthrough, that was originally developed by Colombo Plan, BAP, and the transformation is from a face-to-face platform with an online platform, and then with adaptation to Philippine situation. So this has something to do also with some of the pre-tests that was done on the Part 1 online seminar, which is ongoing, and it will be completed by the end of, almost by the end of July. Next slide, please. Okay, the UTC walkthrough was good for before the pre-COVID, I mean during the pre-COVID times, was 10 days, 8 hours per day, or a total of 80 training hours. Philippines is very young in this field of academic study and research. And so our first step in this regard is to educate our educators in colleges and universities all over the country. Mind you, we have 2,300 universities and colleges, and 33 of these have graduate programs. But those who have benefited from attending the universal treatment curriculum were very few, and about 3 or 4 of them represent the big private schools in Metro Manila. Next slide, please. Okay, that pre-COVID UTC training was excellent. There was, as you know, the sensory experience was complete. All or most of our senses are fully engaged. And then we know this, you have experienced this, we meet new colleagues, old colleagues, we hear conversations, we laugh together, we touch one another, shake hands, embrace, kiss each other. And social distancing is never in our mind. And my own insight is this. It is very helpful to have this sensory, wide range of sensory experiences to have a very rich learning exposure. And I think people will remember well because of the emotions attached to it. Next slide, please. Okay, I'm featuring here 2 of the schools that went through it. One is the Ateneo de Manila University, where I belong. The training was conducted way back in 2018, but being the host university, we invited our neighbor universities and colleges, okay? After this 2018 training, most of our faculty who attended were very much involved in a community-based program development, research, and also a manualizing a community program, which still runs today. And so far, we have already published 7 research studies in international and local journals. And we are this is probably our strength. We are not yet ready to mount a training or an academic course in addiction, but our neighbor, okay, next please. Okay, the De La Salle University, Benilde, was aggressive enough to mount an academic program. So these are the people that you see, and look at the smiling faces. So now they are going to launch, I believe in August, a diploma on the fundamentals of SUD intervention, which is now being coordinated by Verna Felipe. And also the other one is counseling for SUD. So both will be online programs with asynchronous meetings in each diploma. The coverage of the first diploma will be pharmacology, pre-treatment, outreach, and screening. So we're excited about that, and I wish them well, that they will have good participation. Next slide, please. Okay, while that is going on, we organized an evaluation workshop for the courses under the UTC, and so I sort of facilitated 2 workshops, and the objective was really to look into, if you will see the thick manuals here, we have to go through each one, through each course. What you see on the screen are just 2 courses. So there are 8 courses that we have to review. We have to revise the sequence the way we think it should be. We have to shorten or lengthen some sessions, and definitely add Philippine data and other resources to contextualize the training. And this has been quite a meticulous, exercise. So we had a very good output. We were able to decide, to at least decrease the hours for quite a number of modules, and this includes screening, case management, and then we increase a little about other topics that are that we have already studied. And so, next slide, please. So these are the people. These are the alumni of the UTC workshops that have been held in LaSalle and in Ateneo, and we just put our heads together. It was something that I'm proud of, because there was an output, in other words, in these 2 workshops. And what we did was, Vern and I and Mr. J.V. Aquino were ready to pretest what has been revised. We were ready to do it in the southern part of the country, and all hotels, our hotel accommodations. We have a host university, which is also Ateneo, the Davao University, and we were all set to go until the COVID-19 invaded us mortals. So, in other words, next slide, please. We have to cancel the UTC program, which was face-to-face in April. Then we have to shift gears to online curriculum. And we were about, I think there was about 2 months or 3 months that was ahead of us. So we have to do it quickly, because we decided to do it online and revise the module content and all the resources. So next slide, please. So here, if the original face-to-face platform was 80 hours, in this part 1, because we divided into 2 parts, we have, for instance, 30 hours, but part 2 is also another 30 hours maybe, and we have to do that by also being faithful to the objectives, so which is quite a challenge. Our target audience were faculty, guidance counselors, and those who are very much involved in academic services. So that helped us, because it homogenized our audience, and it's easier to trim, add, enhance, etc. Our PowerPoint and our assignments for them. Next slide, please. Great. Next. Okay. So the solutions to part 1, which is ongoing, and part 2, which is in October, I personally label it as 555, so it's easier to remember. 5 days of online lecture, 5 days of homework or assignments, and 5 days of online lecture. So as I said, the pilot test is ongoing. Yes, next slide, please. Now, in this particular case, we are a developing country. Our internet is not perfect, but I still think that technology is our friend. And if you know, next slide, please. Okay, first of all, we can invite participants from all over the Philippines. Philippines is really an island country. It has 7,100 islands. And we can just, tell people, announce, through online that we have this. So initially, we got an initial response of 45, but we only wanted, in the beginning, 20 and 25. And so, because this is a pilot test. But you see, it's fantastic. I mean, that is the potential of an online platform in an island, group of islands like we have. Next slide, please. Okay, what was the online learning strategy? First, we don't have any choice but to have shorter lecture. We really have to be very savvy with our apps. So we have Google, we have Kahoot, and my techie people, the techie teammates were very good at this, and I'm poor at it, so that's fine. And then we have enhanced application exercises outside of the session. If you can't discuss it inside the lecture room, then they do it outside. And then we have expanded reading materials and local resources. I'm very proud of this because it is now highly localized. And then we also provided opportunities for consulting us, the facilitators. Next slide, please. But also technology is our enemy. When we did the launching, many of the participants, and it's very frustrating on the part of the facilitator, choose to be mute, or many hide behind the ID pictures. Then participants, well, some, they prefer to use the chat option and internet connectivity. When we have a thunderstorm, which is now the season for the rains, you just lose some. And they also lost me. Okay. The first 2 days is always frantic. Some 13 people were waiting in the other room while we were already starting to, in another room. So there was confusion in the organization. But, we learned. We can fix that. And I think soon enough, we'll be good friends with technology, with enough exposure, training, and learning. Next slide, please. So in terms of the cognitive learning, there should be a good fit between the lecture time, which is 1.5 hours. At the maximum, we can only do 2 hours, and the target module. So this is the challenge for the facilitator. And then to make it easier, we have to define our audience well, and to make it the interest, and of course the backgrounds as near as possible. And then thirdly, the technical training of facilitators, that's me, and then participants on the different platforms. And I know there's so many that we can tap, but some are expensive, so we have also to look at the cost of each. And so we're just using Zoom for now and be contented with that. But maybe when we have enough, then we can venture to other web platforms. Next slide, please. Okay, what happens next? I'm sorry, I cannot provide you a statistics enough to say whether this works or not, but we will soon have it after next week. I'm going to do this with Verna and FGD in evaluating this new platform. Plus, we also have a web evaluation form that will be distributed. And then thirdly, I think what happens next is that to reinforce, we see the great potential of the online platform in terms of widening our reach in the country. It is cheaper, facilitators are more accessible, and likewise, our target students. We can organize specialized webinars. We're also looking at the consortium of universities in the near future to plan for future academic programs on addiction and related subjects. Oh, we look forward to this in spite of COVID-19. And with that, I end my presentation. Thank you.
Thank you so much.